Thank you for the invitation to talk about clinical experience with photothermal stimulation. So we have a big debate on how we should call this treatment. You know, conventionally people call subthreshold, and this is from the micropulse experience, but it's really, the term is not correct. I will talk a little bit why. And so we settle for photothermal stimulation, and I think that's the best way to approach. So we are going to talk about a little bit about novel approaches clinically with this kind of strategy. So okay, so endpoint management, Daniel already talked about the basic science behind the endpoint management, and so it's a method to allow precise control of levels of dosage of short durations. And the thing that really defines endpoint management is the decision of what is the endpoint you want. So what's the endpoint? The endpoint could be also the threshold. So we have different thresholds. So we have different thresholds. So what's a threshold? So the threshold could be clinically visible threshold. So this is usually what people call subthreshold. If they do see the burn, that's threshold. If they don't see the burn clinically, that's usually what they call subthreshold. So if you see the literature, so there's a couple of trials, not really clinical trials, but interventional case series, calling and comparing subthreshold against threshold treatment with infrared and green and a couple of yellow. So, but when you see the images, there are clear damage in FA or in OCT. So their thresholds are clinically visible, and they call subthreshold because it's invisible clinically. But if you go, for example, for angiography, OCT, and even if you go further to RP viability, that's the endpoint you want, and that's what you need to decide before you treat. So we did a lot of experiments with rabbits to define these endpoints clinically, OCT, FA, and histology, and we went to SEM, so scanning electron microscopy, TEM for transmission. So we already discussed this graph. So this is the basis, the algorithm for the endpoint management. We want to be in this curve to always be in the treatment zone. So we want to treat the retina. We don't want to be below the treatment curve and not above, not to cause any damage. So this is the GI. So this is how we treat. So we first titrate, and the thing about the titration, which is one of the most difficult parts from other treatments like micropulse. I have a lot of experience with micropulse also, and when we treat it with micropulse, we see the literature, it's all over the place. So people there are some groups that do titrate, some groups don't titrate, some groups have one dose fits all, so they keep 750 milliwatts for every patient. Some people, like we used to do a titration burn, and we increase the power by 20%. Why? That's what worked for us. That's the recipe that worked for us. And so that's really not very reproducible. And that's the main criticism about micropulse, because the reproducibility of the treatments between groups is very low. So this we try to avoid. So the decision of the titration, the 100% burn, so the nominal burn will be yes or no. So we do see the first barely visible burn we see, that's our 100%. So in 3 seconds, and in these 3 seconds we do see some faint, like little burn, that's our 100%. So we titrate this by power, keeping the duration by 15 milliseconds. Or 20 milliseconds, but we keep the duration stable, and we go increasing power, and that's our 100%. So this is 100%, and then when you go to endpoint management software, we decrease this energy, and then we don't know, the physician doesn't know which power and which duration is being applied to the retina. And that's a good thing, because usually the physicians don't know how to titrate, so they will maybe increase the power or decrease duration, and that's when the confusion begins. So if you keep this as energy, that's better. So you always keep in the curve, and that's really the goal for endpoint management software. So then we treated, so this is the 100% burn, so it's visibly, barely visible clinically, really visible FA and OCT, so this is 100%. So with this we don't miss. And then when you go to 75, 50, and 30, we go and decrease our threshold, so we only see them as FA or OCT positive, then only OCT positive, and for 30%, we chose 30% because in 30% we only could find one cell once in a while, an OCM, in the center of the burn. So this is something that it indicates that we did treat, so it did increase the hit as the computational model suggests, and we saw some indication morphologically, anatomically, that there's some tissue effect. So that's our goal. So we don't want to go we don't know that if we go below that, we are doing anything other than biochemical stimulation of genes. So it's important to adjust the pattern density. That's a paper that we published with Daniel. Also, if we decrease our endpoints, our thresholds, for a moderate burn to a barely visible burn, the burn itself will decrease the diameter. And if you go for a treatment like a PRP treatment, we need to adjust the density, so the spacing and the number of spots to treat the same area. And if it's the same thing for macula. So this is about ETDRS pattern, a ETDRS grid. So this is very intense burns, a lot of burns very close to fovea. This is the original ETDRS picture, so it's not from my group. So this is the original from the paper. And this is how, if you call I'm treating like ETDRS, you should be treating like this. No one treating like ETDRS anymore. But if you want to apply a treatment that mimics the gold standard, which is the best evidence we have even today of grid macular treatments, we should use the same formula and treat with a larger number of spots and more close from each other. So then I spent 1 year in postdoc with Dr. Palanker, a couple of lasers to the research, and thanks again for Topcon for giving us the opportunity to work with this. Here in the back is actually the endpoint management. This is the first Pascal. This is the infrared that I'm not sure is even work anymore. And so, but I changed from this setting to this setting, which this is my clinic today. My Pascal is really close by to where I sit and talk to patients. So really, I'm trying to use this as much as I can, and with very good response. So, and this is the case. So far, we have about 58 patients treated, eyes treated, so mostly with DME and central serous choroidal retinopathy and BRVO, a couple of cases, and I'm treating some macular telangiectasia. So I'm not going to talk much about these patients here. So this is more difficult cases, but they have not much response to any other treatment. BRVO treats very well with anti-gengenics, but some patients cannot either afford or not inject. So laser treatment for BRVO was the gold standard. It went to anti-VEGF treatment, but we can try endpoint management of these patients too. DME is really the most number of cases that we have. So DME have a lot of patients. In Brazil, still the insurance company don't pay for Lucentis for anti-VEGF treatment. So there's a lot of patients that can't afford injection. So we do treat a lot of photocoagulation, laser treatments. And we also believe that we should combine treatments with either photostimulation or photocoagulation with anti-VEGF treatment. So this is a different part of the story. And chronic central serous retinopathy, it's a disease that it's very hard to treat. So usually acute central serous retinopathy will resolve by itself. But if it doesn't resolve in 4 months, or 6 months, depending on the criteria, it's called chronic, and there's really not much good treatments for that. Some people use PDT, so Visudyne, and it's very hard for the patient. It's a very expensive drug. It has a lot of side effects, and so really in Brazil we don't use much. So there's conventional photocoagulation if the spot it's away from the center of the macula, and with chronic central serous close to fovea, there's not much to do. Micropulse has a good effect too, and so I'm going to talk about the results. So I have so far 6 months of follow-up. So in this follow-up, we do see a decrease in thickness of the central macular thickness in the OCT, and both the maximum and the minimum, so the minimum thickness, central thickness, and most importantly, the vision will gain, and the patients will regain vision in terms of letters in the ETDRS. Of course, this is preliminary data. This could change because some patients did not reach the 6 months period yet, but the preliminary data shows that there is a very good gain in vision, and the OCT, although there's not much difference because the baseline is not thick enough to show a little too much difference, and especially because the normal retina in the spectralis OCT is about, the central is about 300 microns, and they start with 350, usually because the detachment is extrafoveal. And for DME, we also see a decrease in the central macular thickness, and most importantly is the increase in terms of letters of vision. But again, preliminary data, only 6 months. We should continue these results over time, and then probably write the report, the paper. So again, so this is easier to explain with cases. So let's start with central serous retinopathy. So this is a 64-year-old white male that had decreased vision for 8 months. So really chronic central serous retinopathy with 20/60. And the point of leakage, so we see this is the fundus picture, and we see in the FA, this is the point of leakage. So at this area, when you see in the OCT, so this is actually the ICG angiography. So we see a point of leakage very close to fovea. And so this, for conventional photocoagulation for intense, moderate burns, you can't do this. So this is the point of leakage really almost on the fovea or just the fovea. So, and that's what's leaking. So this is the serous detachment of the retina. So this patient had this for at least 8 months. And so what we treat with endpoint management. So our protocol, it's basically we use 200 micron spot size. We use this lens, which is 1:1 area to the retina. This was the power, the power for the 100% burn, which we can see as landmarks. So these are the landmarks in patient retina. So we know that we treated from here to the fovea almost confluently, so it's 0.25 spacing, although we kept 50%, we only treated 50%, but in terms of seeing the spots, it's almost confluently. So for physicians, it's very hard to go beyond that, which is really one on top of each other, so 0%, but I've done it and didn't see much difference in terms of scarring and anything. So we did 30%, 0.25, landmarks on, and it was 538 burns, because this was a chronic, very hard case. And this is the autofluorescence. So autofluorescence is a method of imaging that shows the lipofunctioning of the RPE. So if we damage the cell, the RPE cell, or it will get increased lipofunctioning, increased external outer segments inside the RPE cell or in the space, this will be hyperautofluorescence. So usually where we do apply these barely visible burns, we see the hyperautofluorescent burn. If we apply too much energy, we might see hypoautofluorescent burns. And this is interesting because these burns over here, these are the titration burns. So usually I apply either 2, 3, or 5 to get my barely visible 3 seconds. They all look the same in terms of autofluorescence, and they all look the same as the landmark. So that's good because that's very homogeneous, uniform treatment. That's what we want. We don't want to be intense here and not intense there. in terms of the whole treatment. So I know that I don't see anything like these burns inside the grid because I'm using 30%. And so that's after, I don't know, 1 week, maybe 1 month, but this is the complete resolution of the fluid after the treatment with endpoint management. So, and this is the color, the fundus picture, and we might see some of the landmarks here, sure, not a scar, not something that people will notice if you don't tell them. And so this is a different case. So this is a white female, 61 years old, so visual acuity 20/60 at left eye for more than 6 months. She had a very strange symptom. She said to me that she was seeing butterflies. That was her symptoms. And it's amazing that after the treatment, the butterflies went away and never came back. But that was the symptom, and that was because that she had this kind of fluid. So that's a lot. So this is she had this at least for 6 months, as she refers the symptoms. And this is a very chronic central serous. If we see the autofluorescence, we have hyper autofluorescent area all over this part of the retina, so it's the fluid will come down, and I treated with 520 burns, spots, landmarks on again, and the same pattern, a little bit more power, 120 milliwatts. And so after the treatment, so this is the baseline, and then after 1 month, 2 months, the vision increased, and this is after 4 months, and the complete resolution. And this we can see the whole area, not only the fovea, but the whole area of fluid resolved. And so that's why sometimes you see the center doesn't resolve that much, because most of the detachment was here. So this part here was the most area of thickening. So this is 2020. So this is a different case. This is a male, 32-year-old, white, 20/50. So again, very close to the fovea. So we could only treat this with either PDT, micropulse, and now with endpoint management. So this is the fluid, the subretinal fluid. Again, after 1 month, a very good result. And so this is a very interesting case, because this is bilateral central serous retinopathy. And this patient had these symptoms, he said, at least for 6 months. It's very hard for them to really point when it started, but he came to me and had bilateral central serous. This is the area of the fluid and also the PED, so the pigment epithelium detachment, and very bolus detachment. So we can see here very, the area of fluid. We treated with endpoint management. So this is the pigment epithelial detachment with fluid on the side. So what is the treatment strategy? That I use the OCT to actually mark the whole area of fluid, and we applied with landmarks on, so we can see. It's very hard to see, but if I point, it's easier. We can actually see the landmarks on. So, and this is the resolution of the right eye. So 20/100 to go to 20/20, and it's very hard to see. And if you go to the PED, the PED also went away, and that's how it responded. The right eye with only 1 treatment. The left eye was harder. So this is the final. So the left eye was a harder case. It was above the fovea. So this is the point of leakage. And also, so we have here the area. So it's detaching the fovea. And this is the pattern. So I had to apply more burrs to actually cover the whole area of hyper autofluorescence. And so also landmarks on. So we can see in the whole multimodal imaging, and this is slower response. So we got here, and so we attached the whole area in the posterior pole. But when we saw the area of leakage, So this is, but when we saw here, this was where the area of leakage was. This did not respond in the first treatment, so we had to retreat. So we retreated only this area here, and that's gone. So this is a complete resolution after, so this is after 8 months. So we have 8 months here with not only complete resolution, but stability from the treatment since the beginning. And okay, so for this is for central serous. For DME, Daniel already showed this slide. So this is not actual spots. So this is more or less what how we do it. I actually do treat closer here. We only don't place burns 500 microns through the disc. So we can treat at the papillomacular bundle like this. So this is a case for diabetic macular edema, 54 years old, white, with DME for over 15 years. This patient had bilateral disease, very severe disease. He couldn't afford any anti-angiogenic drugs. Insurance don't pay for him. And so we treated with first conventional, like focal photocoagulation with no success. And then, so this is the OCT before we treated with endpoint management. So it's a very cystic macular edema in the left eye. So this, again, landmarks on 110, so 760 burns. And well, this is the autofluorescence again. And this is the baseline OCT after 1 and 2 months. So interesting that in the OCT we can see the landmark. So actually the landmark will cause damage to the RPE, a little bit of photoreceptors, and this form here is very interesting because this is in the posterior pole, in the macula, and this is how the nuclei and the photoreceptors will connect to the outer plexiform layer. But when you go for 1 month and 2 months, they are gone. So we can see in vivo and in patients, not only experimentally, that the laser burn will restore. So there's a healing process for photocoagulation. So even with the landmarks, which are photocoagulation burns, they will heal. And we will only see the spots in the infrared or autofluorescence because of the RPE proliferation or damage that we caused, not really photoreceptor damage. So the vision got better and keep getting better. So this is the central part of the fovea, and the vision got 20/25, and this is after 6 months. And it's very hard to see it clinically. And with the infrared, we do see the landmarks, so that's a good thing because it's not readily visible clinically. But if you want to see where we treat it, some physicians, even for legal purposes, or sometimes they refer to colleagues and they say, no, they didn't treat you with laser, I don't see anything. For this kind of patients and physicians, maybe to have like a signature, like a landmark, maybe it's good. So clinically, it doesn't matter much. If you treat a confluent, the whole posterior pole, these burns here won't affect the result, even won't affect vision. So this is a different case for the diabetic macular edema, very severe macular edema, and this patient had what is called subretinal fluid, which is an indication of really bad clinical control and bad control for the macular edema. And we treat her with the endpoint management, and the edema resolved over time, and that she had a very nice result. And this fluid almost gone, the vision got better, a couple of cysts, but not as in baseline. So this is more or less the cases. So thank again for the invitation, and we're open for questions.